So now what happens is that given that we have the results of the liquid NGS now available, there is a change of management that takes place. So the patient is then was scheduled for a clinic appointment on 6th of November. And the decision was to switch to osimertinib, which is a tablet, as this was the actionable genomic alteration, as we mentioned, the EGFR that was discovered on the ctDNA results. It was also then discussed as per the lung MDT that given in the case of any progression with the patient, we would then consider switching back to carboplatin, paclitaxel, and atezo or bevacizumab on progression. As part of baseline investigations, an MRI head was performed, which came back normal, and the patient was then commenced on osimertinib on the 11th of November 2023. So we're now almost 3 months into diagnosis and treatment. So this is where a very important caveat comes apart. The patient then comes in with a hospital admission on the 17th of November. And around this time, the patient first comes in, MRI head was done. She was having some symptoms of confusion, confabulation, some symptoms in which we were worried about, is this a brain met or there's progression in the brain? An MRI head was initially done. It was normal. The patient was discharged from the point of care. Patient then had another subsequent ED presentation on the 11th of December with a fever 39.3, chills, and rigors. Point of care testing showed that there were deranged LFTs. At this point, following assessment and management, the patient was discharged. We then go on to give cycle 2 of osimertinib on the 14th of December 2023, and 2 days later, the patient again comes back into the ED. This time, the patient comes back 2 days later with presenting complaint of an acute confusional state. There's ataxia, hyponatremia with a sodium of 115, as well as deranged LFTs. This was accompanied by systemic symptoms of ongoing viral illness, coryza. There was also low appetite and vomiting. Again, another CT had done at the point of contact in the ED showed nil acute disease, but there weren't any brain mets or anything we were acutely worried about. So long story short, if I'm just going to summarize what actually happened to the patient, given the patient's long stay in the hospital, the patient basically, if we go back a couple of slides ago, we did start the patient on chemoimmunotherapy initially before we had results of the liquid NGS and before the patient was considered for NGS. So given the patient was on pembrolizumab, which is an immunotherapy agent, the patient ended up, despite having only 2 cycles, the patient ended up having immune toxicities. So the working diagnosis in this case was immunotherapy-induced hypophysitis, which is lack of functioning of the hypothalamus that resulted in the hyponatremia. There was also toxicity of the hypothyroid, and the patient was then commenced on levothyroxine. There was also immunotherapy-induced hepatotoxicity, which explained the deranged LFTs. As per the IO-MDT, the patient was then started on IV methylprednisolone on the rate of 2 milligram per kilogram. So following optimization of symptoms, the patient was then discharged after a week on the 24th of December. It was then discussed in the immunotherapy toxicity MDT on the 28th of December, and the decision was to continue osimertinib. So this is a scan. This is a 2-monthly interval scans that we did. And as you can see over here, the first scan shows this is the tumor over here. This is the bulk of the tumor. And within 2 months of osimertinib, you can see there's significant reduction in the size of the primary. Same goes with the lymph nodes. You can see lots of hilar and mediastinal lymph nodes over here. And there is a reduction in the size, which shows this is not an end of treatment scan, but you can see that on the interval scan, there has been significant reduction in the size of the disease, but just with after 2 months, with just only two cycles of osimertinib. So concluding this whole scenario, just to summarize what we happened. So we had a lady that came in with classic symptoms, was diagnosed to have metastatic lung cancer and had a failed tissue NGS and the results came back almost after a month. In the interim, the patient was started on chemoimmunotherapy, was given 2 cycles of chemotherapy. Following failed NGS, we then went on to do the liquid NGS as per the criteria. That came back positive. We then started on osimertinib, and the patient had a brief hospital admission due to immunotherapy-associated side effects. So just concluding this whole story, Genomically driven tumors don't always fit the textbook phenotype, and this is one of the classic examples. And in this case, liquid sampling provided us an excellent opportunity to obtain molecular information that avoided a further biopsy. It also avoided potential complications of immunotherapy, which the patient had already developed. And had the patient been continued on the chemoimmuno regime, they could have had detrimental effects on a 70-year-old lady. Apart from that, as you can see, health economic benefits characterizing patients fully, we were able to identify the target population and then result in a dramatic change in the treatment plan. And most importantly, as you guys have seen, the liquid versus tissue biopsy timings have been drastic in the change of treatment. So 6 weeks median time frame for the tissue NGS to come back compared to almost just 2 weeks for liquid biopsy results in significant early start of treatment and avoidance of potential side effects, as well as better compliance in a lot of patients. So that concludes my discussion. I would extend a huge thank you, of course, to Dr. Duraid Al-Rafai, who's been my project lead and my supervisor, and who's been an excellent and has had a pivotal role in this whole project. Apart from that, my oncology consultants, Drs. Jason Chow and Tim Benepal, Dr. Marina, as well as the lung oncology CNSs, Amy, Hannah, and Jen. I also extend my thank you to the respiratory radiology, pathology, and thoracics team at St. George's Hospital, as well as the entire lung MDT for helping me not only recruit, but identify and then sample these patients accordingly. So far, we have almost crossed 25 to 30 patients within a 3 to 4 months time, and we're hoping to continue this in the future. And I will leave the floor to any questions to me and to my consultant. Thank you.
That's amazing. Thank you, Hamna. That was really interesting to hear that case. Just on the questions front, if it's okay, we will pause. We will hold the questions. So feel free to put them in the chat or just kind of keep them written down. We'll go through them all at the end if that's okay. Otherwise, yeah, that was really interesting to hear. So thank you. I will share my slides for Nikki over at Princess Royal University Hospitals, who we've got presenting next, and then we will. So Nikki, can you see the slides? Can everyone else see the slides?
Yeah. Shall I? Can you hear me? Okay.
I can. Yes. So please feel free to just direct me in terms of the navigating of the slides.
Yeah. Hi. So hi, I'm Nikki. I'm one of the lung cancer CNSs at the Princess Royal University Hospital, and thank you very much for asking me to take part in this presentation today. And yeah, please, Wesley, move my slide on. So we're a district general hospital. We've got a large lung cancer service here. We diagnose around 240 cases a year, and I just wanted to go through an individual case and why, like, the ctDNA has made a big difference to us. One of the challenges we've had recently is that, and I've been a lung cancer nurse for many years, and it seems to be an ongoing problem with the time the capacity issues for biopsies, the complex pathway in lung cancer, that it feels that there is, it can take a month to 6 weeks to get a diagnosis, and in advanced disease, we clearly know that people can deteriorate in this time frame. So anything that we can do to speed up the diagnosis, that's what our aim is. And so we've had particular problems over the last few months as well, because we've had doctor strikes, we had a new computer system, and then also our biopsies went to being processed in-house to going over to a regional hub. So we were looking at the time frame to get from the diagnosis to when we got the final molecular panel back was on average about 4 to 5 weeks. And so when we were asked whether we would be wanted to take part in the pilot, we were like really keen to be part of that. And I've put 29 samples there, but actually I've done one this morning, so we're now at 30 samples we've sent. So if you could just move me on, please. So I just wanted to go through like a time frame of a real patient and the sort of from a nursing perspective as well. And so my patient is a 46-year-old female. She's a never smoker. She had back pain in August, and she thought it was, she saw her GP and it was thought to be sciatica. She bought a new mattress. She was, trying to self-manage it, but it was getting steadily worse. She's got no other significant medical history. She's a single mum. She's originally from Cameroon, and she's an office worker. So she attended A&E actually 3 times between August and October, and her third A&E attendance was only a week apart, because so her first 2 were with backache and getting like severe, and then her third one was that she was now becoming much short of breath and a lot sicker. And so in A&E they thought that this might be a PE, and then they went on to do a CTPA, and this showed, unfortunately, that she had very advanced cancer, looked like a primary lung cancer with a large lung mass in her right lung, but also she had a PE, a pericardial effusion, bilateral pleural effusions, and lots of lymph nodes. And also, because of the fluid around her heart, there was concern about a tamponade, but she also had an echo in A&E, and that didn't show any evidence of a tamponade. So she was told in A&E that she had likely lung cancer, and she was started on steroids and anticoagulated. So at this point, she wouldn't have been referred to me because it was a suspected diagnosis, or I've got 2 other colleagues. So we didn't know about her at this stage. So could have the next slide, please. So this was her presenting chest X-ray, and you can see just on the right lung, you can see the mass there, and then the large pericardium. And can I have the next one, please? So I've done it as a sort of to discuss this case in the kind of the time frame of how many days it took. So by day 2 in hospital, she was admitted. She was probably at this stage performance status 2, and she was seen by the respiratory team and the acute oncology team, and there was a plan for a scan, which then happened the next day. And the scan showed further disease, and the MRI scan showed that she had multiple bone lesions, which accounted for her back pain. And the plan was for a supraclavicular biopsy, so similar to the previous patient that was just presented. And then this was probably the safest way to biopsy, given the fact that she had pulmonary emboli. So she was then, a few days later, she was referred to palliative care because of her back pain, and they actually referred to us because this patient was really very distressed by the potential diagnosis of advanced cancer, and so they asked us to get involved. And so we went, and sometimes with young patients you don't see them in case it's lymphoma and things like this, so we often are anxious about saying it is a definite lung cancer before we get the final tissue biopsy. But actually in her case, I was happy to see her because we had this option for her to perform a ctDNA test, which I did myself that morning, and then later on that afternoon she was having her biopsy. And actually for having a biopsy on day 7 is pretty quick for us, because if she'd have needed an EBUS or a bronchoscopy or a CT guided biopsy, that would have taken a lot longer to organise. So then the next significant sort of date for her was day 13, where we had our lung MDT, and we did make the diagnosis that it was indeed a cancer, not lymphoma, and we were then waiting for the final immunohistochemistry to confirm that it was a lung cancer. Next slide, please. So then the next day, she's still deteriorating, and so she remained under AOS all this time, and then we felt that we needed to get her as well as possible, because we had a young patient that we wanted to be able to offer her anti-cancer treatment. And so a plan was made for her to have radiotherapy for her to control her back pain, and she had that the next day. And so then the sort of week later, we had it confirmed that this was indeed a stage 4 lung cancer, and she was going to be referred to our oncologist to consider systemic treatment. And I was able to go and see her that afternoon to tell her and update her that it was indeed lung cancer, which is what we had initially suspected. But it had been noted that this patient was clinically deteriorating, and she was probably now performance status 3. And we were quite concerned because she was getting more and more breathless and, at the point of being critically unwell. Fortunately, the next day, we got the ctDNA results emailed to us to confirm that this was an ALK positive lung cancer. And this obviously gave us the option of giving her very quick treatment. And so we informed her and gave her the written information about the drug, and then requested the brain as part of our staging. And so then 2 days later, which was the next clinic with our oncologist, he was able to virtually review her. And now, because even though we've had challenges with our computer system, in her case, this was a benefit because our computer systems are now linked, and he could consent her virtually, and he prescribed her drug. So can we just move on? But which wasn't unexpected, even though he prescribed the drug, we had to wait for the drug to come in, and so she then went on. She did then deteriorate. And if you just wouldn't mind just forwarding to the next 2 slides and then take me back again. So this was her original scan, which shows the lung mass, and then this, if we go on again, this is the scan that was done 3 weeks later that shows the enlarging pericardial effusion with features of tamponade, which had obviously progressed very quickly in the 3 weeks that she'd been in hospital. You could take me back to my timeline. So then the drug was, as we got the drug as quick as possible, and she started it at sort of day 27, and then we went on to do an urgent pericardial centesis. So then we'd already requested that her molecular pathology was expedited given her age and how critically unwell she was, and so we actually got our molecular results back quite quick as well, which did confirm as well that they correlated with the ctDNA that she had an ALK translocation. And so she then, but even now, after the pericardial centesis, she was definitely improving, and this actually was Christmas Eve, and she went home, and then she was seen in person at Guy's by the oncologist, and she was noted to have a definite clinical improvement, and fortunately she was able to remain at home. So if we can just go forward. So then, in summary, for us, if we'd been relying on without the ctDNA, the earliest time we could have treated this lady would have been day 43, because that would have allowed for the reality of you can't just treat the patient on the day we get the final molecular results back. It has to be that we get the patient into a clinic slot, and also they have to be well enough. And so we actually treated her about 20 days earlier than we would have done normally. And so I think in her case, from my opinion, because I saw her regularly throughout the whole admission, I think this actually saved her life. And so and also the thing I noticed as well was that when we were able to offer her the ctDNA, which is the day 1 of us seeing her, it felt to her like something was happening, and her anxiety levels were a lot less, and that of her family as well. And so it was just such a positive thing to be able to offer, where it felt like we would get the answer much quicker, and she'd have a chance of having some treatment. And I have actually spoken to her this morning, and she's out shopping. She's so much better. She's coming down on her painkillers. She's talking about going back to work. And so, it's been such a success for us. Thank you.
That's amazing. Thank you, Nikki. Thank you very much for that presentation. Again, if there are any questions, please feel free to put them in the chat, whether it's about the particular case or anything about ctDNA in general. Please feel free to put that in, and we'll get to those in a sec. I will now hand you over to Dr. Alex Georgia at Guy's and St. Thomas. Alex, are you happy to share your slides? Perfect. Thank you. Not sure. You might be on mute, Alex. I can't quite see. Anyone else hear Alex there, or is this just me?
No, can't hear him.
Alex, are you able to unmute?
Yeah,
Oh, there you
I
go.
am sorry. I shared the slides and then I realized I couldn't find the button to unmute myself. So let's just do it again. Sorry.
Yeah, no problem.
Okay, so hopefully now you can see and hear me and see me. And let me make the full screen. There you go. Okay, well, full screen hopefully coming up. Okay, so I'm Alex George. I'm one of the oncology consultants treating lung cancer at Guy's Cancer Center. And also take all the referrals that originate from the Princess Royal that Nikki just presented a case. So I think I have a few short clips of cases really in this presentation, but I wanted to start with the whole idea of a cancer center, and this applies to other places as well. For example, Kent Oncology, further southeast, and it is important when it comes to the ctDNA pilot, and hopefully in the future when we be in the standard of care. So the cancer center such as Guy's covers the southeast London area, but the actual lung cancer pathways start at all the referring hospitals, in particular at actually the Guy's and St Thomas, but also King's College, which has Denmark Hill and Princess Royal, and then the Lewisham and Greenwich Trust, the Queen Elizabeth at Woolwich, and the University Hospital at Lewisham. So all these hospitals have their own diagnostic pathways. The oncologists are employed by Guy's, and most of our patients are seen at the Guy's Cancer, which you can see here. But this pilot, when it started, when I was first introduced to the idea, it did pose a challenge, because up to that point, we were used to using ctDNA in medical oncology, mainly in patients that maybe were diagnosed many years ago and they didn't have the molecular diagnostics when they progressed on treatment, or patients that are typically EGFR that we wanted to check secondary mutations. So this pilot, though, the important point is that it is at diagnosis before biopsy or at biopsy that the ctDNA was taken, which meant that it had to go back a step from an oncology point of view, go back to the source of the diagnosis, which is the respiratory teams effectively. So the challenge that we had at the beginning, when I was starting to sort of set this up, was that the oncologists were too late in the pathway to actually be actively involved. And actually, the most important people here are the respiratory physicians and really the lung cancer nurse specialists that are involved along the pathway of the patient. So at the moment, I'm involved in Guy's. The oncologists are based at Guy's, and I see some of the patients that originate at Guy's, but also we go to the peripheral hospitals, and my peripheral hospital is the Princess Royal. So I'm involved in Guy's and the PRU in terms of the ctDNA pilot. So there is at least 27 samples that we sent at Guy's, and as you heard from Nikki, the 21 has already gone to 30 in the 2 weeks that I had these slides done. So we are recruiting patients in these faster in the past few weeks for sure, having started really in the summer of 2023. So a few cases really to show the utility of these tests. The first one is a case from Guy's, was a 70-year-old man that was previously fit and well, who presented with breathlessness and weight loss. He's a non-smoker, no asbestos exposure, some past medical history, but nothing significant. So he presented with a whiteout of the right hemithorax and had a chest drain done and a pleural fluid sent on the same day, on the 7th of November in 2023. And a CT was done subsequently that showed a large right upper lobe necrotic mass, as well as right adrenal mass. And a ctDNA taken was at that point taken, because at that point we know this is stage 4 lung cancer radiologically. So as per this pilot, the ctDNA can be done at that point. The MDM was done a week later, and it was staged as lung adenocarcinoma based on the cytology that we said from the drain, and it was staged as T4 and 3M1C. PD-L1 was negative, and the molecular diagnostics were pending. Of note is the Alcros ones were known, and these come out quickly because it can be done by the pathologists on immunohistochemistry, but the DNA and RNA report was awaited, and that's the one that takes longer. So on the 29th of November, we get the ctDNA report that shows an exon 21 EGFR L858R mutation, which is known as a tier 1 mutation that basically offers this patient an option of first-line osimertinib in the advanced setting. And indeed, a few days later, I saw him in clinic and started him on this treatment. The report from the molecular diagnostics with the DNA RNA results came out actually 3 days after he started osimertinib, and that did confirm the EGFR exon 21 L858R. So this patient who started on treatment prior to actually having the results from the biopsy showing that he had an exon 21 mutation. And at the moment, the most recent review that's seen him on the 18th of January, and has clinically improved, and he's under follow-up in Plura, but he has not needed any further drains. And you can see his X-ray on the right on the 29th of December compared to baseline looks improved, but more importantly, clinically, he's better. He put on some weight and he's more mobile with very limited toxicity. So in this case, the ctDNA allowed us to start an effective treatment at least a week before we actually had the biopsy results. The second case is from the Princess Royal Hospital, and it's an 83-year-old lady that was fit and well, despite her age, actually cared for her husband, non-smoker again, and lived independently. PS1, presented with right shoulder pain, and then further down the line developed pain across the anterior chest. And the CT showed a large right upper lobe mass that was locally invasive, but also pulmonary metastases and lymphadenopathy, and the ctDNA was taken on the same day again as a CT. At this stage, a biopsy was not done. But as we said, if a CT suggests that it's advanced malignancy that will be compatible with lung cancer, ctDNA can be taken at that point. An MRI spine was done when she developed this pain in the back and across the chest, and showed that she developed cord compression at T3, unfortunately, and went on to have radiotherapy. CT-guided biopsy is now done at this stage. It was a difficult case to find a biopsy site, but a CT-guided biopsy was done on the 24th of the 11th, so this is already 11 days after the ctDNA was taken. And by the 29th of November, the ctDNA result was seen, and actually the case was discussed in the GTAB, in the Genomic Tumor Board meeting, where they note the results of the ctDNA being another exon 21 L858R mutation, and the recommendation is actionable EGFR variant identified. The patient is then discussed at this point. Interesting, the patient is discussed again on the 4th of December. That is when we have the biopsy result confirming lung adenocarcinoma with molecular pending, and at the same day I see her at the PRU and start her on osimertinib, which she was able to start within 48 hours of actually prescribing it. And interestingly, the result, because there's Christmas around that period as well, on the 4th of January, a month after starting treatment, we have confirmation of her EGFR mutation. Unfortunately, she remains symptomatic despite the radiotherapy and the response that you can see here on the primary. Her main symptoms remain with a neurological deficit that she had from the spinal cord compression, but she is in herself gradually improving with rehabilitation, and she continues on osimertinib because she's likely to continue to offer her a benefit, as we can see here from the scan and also clinically. So at this stage, I would like to sort of summarize that the cases that I've just shown you really identify target driver mutations that offer targeted therapy options for our patients with advanced lung cancer. But and we've seen already cases that have been presented before that were of the similar principle. And indeed, the previous patient that Nikki presented, I was involved in, had an ALK rearrangement. So it's not just EGFR mutations that we can identify from this test, it's also rearrangements such as ALK. But then I wanted to also present some cases that really show the ctDNA utility beyond just identifying, genomic drivers that offer patients direct treatment options. So the first case is a 71-year-old ex-smoker. She was, to summarize the case, she was staged with a T2 and 2M1 lung cancer. In other words, she had a right hilar mass with bilateral lung metastases, widespread nodal metastases, and pleural and skeletal metastases. She had a pleural drain and a cytology confirmed TTF1 positive lung adenocarcinoma. And on the same day that she had the drain, the ctDNA was collected. The ctDNA was reported as having a KRAS G12V mutation. Subsequently, the molecular diagnostics on the cytology sample has started coming through, showing that there is PD-L1 ALK-ROS and were all negative based on IHC. So the immunohistochemistry results were negative, but the DNA and RNA analysis had failed due to insufficient samples. Despite repeated pleural samples, there wasn't enough material. At this stage, the patient was quite symptomatic, and because of the fact that I had a ctDNA that showed a KRAS mutation, and the fact that the PD-L1 immunohistochemistry result was already available, I was able to make a plan based on the fact that she's got a KRAS mutation and PD-L1 negative and adenocarcinoma, and started on carboplatin pemetrexed pembrolizumab. And I didn't repeat the biopsy because at this stage, I thought it would add another potentially 4 weeks of her pathway, and she didn't really have the time for this. So in this case, identifying a KRAS mutation, which was in line with a history of smoke or being a heavy ex-smoker, and really allowed me to come up with a plan and start treatment quickly. And she's now had a scan that showed favorable response in about 10 days ago. The next case is a patient that is another patient that presented at the PRU with breathlessness and back pain. And to summarize this, again, staged as stage 4 metastatic, was a mixed adenocarcinoma and small cell. And this is a slightly different case, but I just wanted to show how much information you get from ctDNA, really. So this patient's CT showed a collapse of the right lung, a perihilar right tumor, and bulky mediastinal lymph nodes and liver mets. He had a pathological fracture on the MRI, and the material, the diagnostic pathology was again from the pleural fluid. The pathologist thought that there was a combined small cell and lung adenocarcinoma, and I did challenge her in the MDM to sort of try and give us a percentage, which, as what it was the predominant pattern. She said it was sort of 50-50, although something that, it's not really easy to define. The ctDNA came back at this stage showing an RB1 variant and TP53 mutation. And these RB1 loss and TP53 mutations are really genomic hallmarks of small cell lung cancer. At this stage, I was already inclined of starting small cell type chemotherapy, but the results of the ctDNA made me even more confident that this is the right approach. And indeed, later the molecular diagnostic did not show any genomic variants that would have given her any targeted therapy options. Given him a targeted therapy option. So I started him with carboid topocyte atezo. So I guess in this complicated histological case, the genomic abnormalities suggested that small cell is indeed probably the predominant issue, and the one that's going to cause him probably the clinical deterioration if we hadn't treated. So it was an interesting case of where you'd see ctDNA utility beyond just what we've discussed. But I did want to say that ctDNA has not always been as informative as we wish. There's no question that ctDNA is a great test, and it has been an absolute game changer, really, in terms of starting patients' treatment quickly. But I have 2 cases here that I remember that I wish the ctDNA was a bit more informative. And interestingly, these are both earlier stage cases where we consider neoadjuvant chemoimmunotherapy, where we need to show that they don't have a genomic driver before we start chemoimmunotherapy in the neoadjuvant setting. So the first patient was a T4N0M0 lung adenocarcinoma. So locally advanced. There was a questionable bone met, which we couldn't really define on a PET and an MRI. And the ctDNA report, and this was one of our first patients in phase 1 when we were working with the Roche panel. Now we moved on to the phase 2, showed no reportable genomic alterations were detected. So because we're very anxious to start chemoimmunotherapy in the neoadjuvant setting, I've seen him in clinic and started planning for carbapenem and nivolumab while the molecular diagnoses were pending. But interestingly, 3 days later, an EGFR exon 19 mutation, 19 deletion was found on the molecular diagnostic DNA panel that was done on the biopsy material, and therefore I had to change my plan to osimertinib at that point. So in this case, it was a negative ctDNA result, which actually was probably because of not enough material as opposed to true negative result. And similarly, the case 2 was again a T3N2 single agent N2 lung adeno, which the surgeon thought it was operable. And therefore, we decided to pursue the neoadjuvant chemoimmunotherapy pathway. The GTAP report in the ctDNA show no reportable genomic alterations, but likely low ctDNA content. And then unfortunately, well, I guess the patient needed to wait longer until we get the report, because at that point, this result could not exclude that there was an EGFR mutation, let's say. Indeed, 3 weeks later, KRAS mutation came back on the on the biopsy molecular diagnostics, and the patients went on to have neoadjuvant chemoimmunotherapy, is done well and is waiting surgery. So overall, it has been, as I said, a game changer, and it's really improved the pathway of patients, and we're really keen to carry on. But there's not going to be a complete substitute of pathology, and that's important to also appreciate. There'll be some cases where you still have to wait for the DNA RNA panels. But more importantly, as an oncologist, I have to highlight that this really work is really done both in the Peruvian guys by the CNS teams, and also the respiratory physicians who are really recruiting these patients, and us as oncologists are in a better place in starting patients quicker and with more confidence because of these results. Thank you.
Wonderful. Thank you, Alex. Appreciate that. What I will do is I will share my screen, and we essentially will open up the floor for questions, I believe. There have been a few questions in the chat just whilst I try and get my screens set up again. Nirupa, I'm not sure if you're able to answer some of those first questions that we've got there. Thank you.
Thank you. Yeah, so I can see one that's there, and if you're still on the chat, please feel free to jump in, or if and add any extra points. So, is the pilot only for non-small cell lung cancer? Yes, it is. That's right. But it is, as I was saying, that through this pilot and through a more widespread use of ctDNA, we envisage that the indications for testing to other cancer types will increase. At the moment, also, it's important to bear in mind that there may not be a histological diagnosis when the ctDNA sample is sent. So this may include, therefore, some small cell lung cancers and neuroendocrine tumours, etc. So that is one thing. And, NHSC were cognizant of that, but a lot of it is also to try and then look at the impact in terms of turnaround time with ctDNA testing. And so just to clarify that it's not only for if there's failed tissue sequencing, because actually I think one of the things, and as Alex's case highlighted, you know, there probably isn't, unfortunately, we probably need to be a bit more flexible and have a hybrid approach. I think this is what we're seeing, that there is the ability to do one type of test, and if it doesn't work for whatever reason, then we are flexible to look at another approach. And what I will do is, in the chat, I will put in a paper that was published by Sanjay, giving their experience of tumour testing and ctDNA testing. So that was one of the questions. I hope that answers that question. Wes, do you want me to look through? And I'm very happy for the panel members to come in. And I don't know if there was anything further you wanted to add, Alex, with regards to that question.
No, I mean, it's important to appreciate that this is patients that we don't know they have non-small cell lung cancer. And we had cases that were sarcoidal lymphoma because you just don't know. It looks like mediastinal lymph nodes with possible hilar primary and PET positive, and this could be sarcoid. But I guess that would be the drawback of having this pilot. And we'll have to come down to the cost effectiveness of how many cases of that. But we haven't had that many cases, to be fair. But it is worth doing that for all patients that have radiological evidence of lung cancer.
I suppose then in the health economic evaluation, it will be looking at the cost of those additional tests where there wouldn't be an indication versus an additional biopsy, CT guided biopsy, additional procedure, and so forth. And so if I just move on to the next question, which is in terms of, is the liquid NGS using a targeted panel? Yes, it is. And so it is a targeted next generation sequencing panel, not whole genome sequencing, which is, and in terms of depth, I don't want to misquote, but I think if I remember correctly, the median coverage is something like 5,000. Now, whether I need to clarify whether that's the same for the RMH 360, but I imagine it is. And then looking at the specifications for there may be people on the call that will be able to add to this, but these are the specifications of the Guardant 360 panel, and in terms of the limit of detection. So the coverage is it has to be far greater in order, especially for ctDNA, in order to be able to sensitively detect these variants. And I've just put something in the chat that may be of interest, and also gives an indication of the different genes that are covered through this ctDNA test as well.
Thank you for that. There's an interesting question here as well that I think would be great to open up to all the presenters, as well as yourself, Nirupa, from Edith, and it's just asking around, does the panel think that ctDNA is just as useful in TNM, T1, T2, N0, M0, or is it best in more advanced cancers? And then a second follow-up question is, how receptive are the oncologists to this new method in comparison to the usual method of genetic mark testing? So I'm not sure if anyone is happy to answer that. Alex, Deraid, Nirupa, Hamna?
The current pilot is more for sort of stage 3, 4, so the T1, T2, and NOD will not be included in this pilot. But I've shown some cases that were stage 3 that were negative in terms of ctDNA content, if you like, information. But actually, if you look at the data, there is a variability, but there is up to sort of 75 to 80% ctDNA detectable in the literature for stage 3 cancers. So I definitely think it's worth continuing the stage 3. I don't really know about the T1, T2s because we won't really get the answer from this pilot. I don't know whether Nirupa, you have anything to add on that, maybe.
Yeah, I was just going to say, Deraid, did you want to come in first, and then I'll come on?
Yeah, I think so. So I think there is utility for liquid biopsies in low stage tumors. So if patients have things like an EGFR mutation, the phenotype of that cancer is different. So for example, they'll be more likely to metastasize to the brain. So we reflex all lung cancer patients' tissue reflex, and anyone who does harbour an EGFR mutation, even if it's low stage, they do have a slightly different surveillance program. So they will have interval brain imaging, for example. And also, as this program starts to develop and evolve, there are, of course, surgical cases where having mutations is really important. So having genetic alterations in EGFR and soon ALK will be really important in these patients. So although it doesn't necessarily fit within the eligibility criteria at the moment, it is really important going forward, because there is there's a huge amount of influence that this information can provide in the lower stage tumours.
Yeah, and I suppose it, it highlights that, but the problem is in terms of sensitivity and the limit of detection in, and I think as I showed in the slides, the issue is the ctDNA or cell-free DNA may not be shed adequately to be detected in the blood sample in the lower stage tumours. And indeed, in terms of indications, this is for advanced stage cancers, so inoperable cancers. I think there will be, with advances in technology and the use of ctDNA for minimal residual disease, then there may well need to be different technology applied, or different panel tests for the earlier stage cancers to be able to sensitively detect genomic changes. And I suppose this is also why we need a hybrid approach, that we need to be flexible in having ctDNA testing, but also being able to do tumor testing where we don't detect something by ctDNA. So I think that the test directory will continue to evolve to try and capture the different scenarios. And indeed, now in lung, you still need genetic testing for your early stage cases. Indeed, because I imagine to determine best adjuvant therapy. Is that fair?
And also neoadjuvant. So that the genomic landscape of a tumor now is really important, pretty much in every part of a patient's lung cancer journey. So there are certain treatments that where genomic testing is a prerequisite before we give them the treatment. So chemotherapy and immunotherapy patients, preoperatively, we do need to know their EGFR and their ALK status. So yeah, of course, it doesn't necessarily, there'll be challenges doing that with the liquid platform, but certainly from a tissue perspective, it's critical.
Thanks. And then I was just going to say, Nikki, it was really interesting to hear about your case, so thank you very much for that. I think there is a question for you. I don't know, in terms of number of patients. I don't know if you can see that in the chat. And about how organising the blood test, whether, and I think this is an important pathway question in terms of whether this is in the respiratory or oncology clinic.
Oh, right, I've just seen the question. Yeah, there's 3 of us in the team here, 3 full-time nurses. We cover every 2-week wait clinic, and then also we really are trying to be very proactive about ED and ambulatory, about the emergency presentations, so that we get called to help them with the breaking bad news, really. So then, because radiologically we can often tell whether this is an advanced cancer, and we know that if us nurses are involved early on, we can, because still the perception of lung cancer is that there's, it's a very poor outlook, and we know that's not the case. So we like to be involved as early as possible. And so we're the best placed ones to do the ctDNA. So I have to admit, it has been a lot more work for us than I thought, mainly the data collection, because that feels very administrative. And so I could do with some help with that. But of course, that's like, I think I haven't got much chance of that at the moment. But the benefits outweigh the work that we're putting in, because it is just a blood test, giving out a leaflet and then sending it off. I thought I was a bit daunted in the beginning about sending the packets off, but that's absolutely fine. Takes 5 minutes.
I think
Thanks,
thank you for that. Yes, I think it really emphasizes like how we also, the devil is in the detail, and we need to understand the pathways, and the challenge, I suppose, is that there are slightly different pathways in each, as always, with each individual hospital trust, etc. But the true advantage is if the sooner the testing is sent off, then at least actually something, as you say, is being done for the patient, and the sooner that result is available, the easier it is to then tailor the therapy accordingly. Wes?
Thank you. Thanks, Rupa. Yeah, thanks, Nikki, for raising a really good point around the data collection. Just quickly to clarify, because I was trying to manage time within the session, so I didn't cover it, but the data collection, for those who aren't aware, some of the sites who are involved had to collect data, and that's for the health economics analysis that we talked about, which obviously does add quite a significant administrative component to the pilot. That is purely for phase 1 and 2. So whatever the phases going forward for phase 3 and onwards won't have that data collection, because the health economics analysis has been based off phase 1 and 2. So I guess that's just something to keep in mind for other sites going forward, that theoretically that side of the kind of the administrative burden should fall away, which hopefully is positive as well. But yeah, really interesting to hear Hugo's perspective. I'm interested in this kind of final question that Edith put through as well, around how receptive the oncologists have been to this kind of method. So I'm not sure, you know, those of you who's chatted with your teams, etc. It'd be interesting to find out whether you find generally people are quite receptive, and if not, potentially why that might have been the case, like what the concerns might have been.
I mean, obviously, being here, I'm very biased, and I think obviously, guys, everyone is receptive. I think the main issue is how you incorporate it in the pathways. For example, there's no one that is not keen on having ctDNA as part of a diagnostics. Let's put it this way, and I'll be surprised if you find an oncologist that isn't. I think the biggest issue is actually having that information available when you see the patient in front of you, and that is because they're not necessarily part of the MDM information at the moment. The GTAP is separate from the lung MDM, and actually this is the next challenge that I think I have in terms of, or that I think is the next challenge from a pathway point of view. The first one was actually getting, you know, CNS and respiratory teams really in charge of these, which I think, at least in the 2 hospitals that I presented, has been very successful. But then the next challenge, I think, from an oncologist point of view, is actually having this information. So at the moment, for example, in the PRU-MDM every Monday, I keep saying the same thing. Has ctDNA been done? Can you put it on your MDM outcome? So at least I chase. And I think that is where the next challenge is for the oncologist. We want to have the information, but we want to have it readily available. And I guess that would be with time when it becomes more standard, as opposed to sort of an additional test that may or may have not had. And the new electronic system didn't help.
I suspect we're preaching to the converted here, Alex. So I absolutely agree. And I think, you know, the aim is that they should be, well, what NHS England are aiming for is what they're calling a unified genomic record. So with the pathology, molecular pathology, and all of the genomic testing that has been undertaken in one place for the patient, rather than us having to look at different in different places, different systems, so that we can then make that decision for the patient. And then I would just flag that we are reviewing the results that are coming through. So a lot of them will be straightforward, standard of care results, and you know the oncologist will be very familiar with the approved therapies, and I think especially in lung cancer, which is a bit of a poster child in terms of molecular therapies. But what is interesting, and this is because of work that's been published from Memorial Sloan Kettering and other centres, is that occasionally we do see potential inherited cancers, or a risk of a potential inherited cancer identified. It's in a very small percentage. This is an example of something that we would then review in our GTAB, get advice from our genetics colleagues if as required, and actually ask if there is a family history, or consider whether this may be appropriate and referral to genetics may be appropriate. number one. And also, sometimes you will see that there may be things like a BRCA mutation that's flagged within the Guardant report. And in those cases, with what we will also try and do is just confirm or reassure that this is not the other way as well. It is unlikely to be an inherited cause. So I know that it won't be pertinent germline findings as in a cause for the lung cancer, but it's just something that, you know, we are seeing more and more as we do more and more testing.
Thank you, Nirupa. Are there any final questions? I did see there's one that we missed. It's a question to, I believe, Hamna. I think this was your case around why the NGS failed. I'm not sure if you know the reason off the top of your head, or Durade. If not, that's totally fine.
Scanty tissue.
Okay, there we go.
Yeah,
Thank you for that.
That's always the case for the vast majority of cases.
Great, thank you for confirming. If you're registered for phase 2, will you automatically be registered for phase 3? Yes. So essentially, I will be reaching out to you guys. So I know everyone who's involved in phase 2, so I will definitely get out and get in touch with you guys. The key thing is it's really hard to know who we haven't reached. We've tried to communicate in many kind of formats and forums. So please, if you are interested and you haven't been in touch with us before, definitely please email me. This key thing, if I can stress anything else, so I can keep you guys in the loop. Otherwise, if there are no further questions, I think we'll leave it there. I might share my slide one final time just to say thank you. Thank you to the presenters in particular, and thank you to the sites who have been involved. And then also thank you to Guardant for helping with kind of the education sessions and getting the CPD accreditation. So for those who weren't aware, this is a CPD accredited event. We'll kind of do that in the background for you guys. If I have any concerns, I'll reach out. And then one final reminder is just if you do have the time to complete the survey link that I believe has been put in the chat. It just helps us understand, really the key thing is so that we can know what you guys want to know about ctDNA going forward. That's probably the key thing we'd like to get out of that. But otherwise, thank you very much, and I hope you all have a great rest of your week. Nikki, were you about to say something?
Wes, you've got one more question in the chat
Oh,
that's
great.
just come in. So if you want to enroll now, if we want to enroll now, can we start now, is the question.
That's a really good question. Unfortunately not anymore, purely because we have limited samples allocated for phase 2, and we're kind of slowly running out of those as we get closer towards phase 3. So we don't really have enough samples anymore to be able to onboard new sites. So the key thing is just waiting for phase 3. And as soon as we know about that, really, we can get you guys involved.
But presumably for phase 3, then that should be fine. But it's just a case of timing.
Correct.
Thank
Wonderful.
you.
Thank you, everyone. Take care.